Hi, guys, it's Dr. Sadaf, and I just wanted to give you an update as to what is going on. So, I have opened up my practice in Chappaqua, New York, and I'm currently accepting new patients. So, I want to invite you to come and become a patient of mine. If you've been listening to this podcast, you've been listening to the episodes, you are finding so much value in all of this. I want to invite you to become a patient of mine and come see the difference with a doctor that actually has time to listen to you and support you through the transitions that you may be experiencing, whether they're perimenopause, menopause, or you're experiencing any type of sexual dysfunction. And of course, I do annual GYN exams as well. So if you're not having any problems at all and you just need a regular exam done, I am more than happy to help you out. So make sure you check out the practice. It's called FemV Health, and the website for that is www.femvhealth.com. And make sure you look that up. The phone number for the practice is 914-538-2534. And make sure that you go and check it out. Check out the website and make sure you book your appointment today. Also, I have just started a new Facebook group. It's called It Might Be Menopause Support Group by Dr. Sadaf Lodi, FemV Health. And I'd love for you to come and join that Facebook group, because in that group, we'll be talking about different ways that you can get support and education as you go through this important transition in your life. It's also about building a community that is going through the same things that you are. Oftentimes we feel that when we go through things in our life that we are the only one, but I'm here to tell you that you are not alone, and that there are so many other women going through the same symptoms that you may be going through, whether it's hot flashes, night sweats, mood swings, vaginal dryness, pain with sex, brain fog, joint pain, dry eyes, any of those things, so come join us in that Facebook group. It's called It Might Be Menopause Support Group by Dr. Sadaf Lodi, and that's on Facebook. So come and join us in that community. And I definitely look forward to welcoming you there. And make sure that if you have any questions about any of the podcasts that I do, that you either DM me or email me, and I will create a podcast just for you, because you are a loyal listener and subscriber, and I would love to answer any and all of your questions. So if you have any burning questions that you are wondering about, please make sure that you email me at hello@femvhealth.com and let me know about your questions, or DM me on Instagram or TikTok, and I'll create an episode just for you. And as always, make sure you like, share, and subscribe to this podcast. As you know, I am looking to get over 100,000 downloads by the end of this year, and I'd love for you to help me out in that endeavor. And so please share and like these podcasts, download them, and let all your family and friends know, because I know there is not much information out there, and some of the information out there is not actually factual. So you want to make sure that you are getting your medical information from a board certified OBGYN that knows and has studied all of this material, whether it's sexual medicine, perimenopause, or menopause. So looking forward to hearing from you. And now to the episode. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi, and this episode is everything you need to know about sex, menopause, hormones, and everything in between. Before I get into it, of course, this is not meant to be any type of medical advice. If you have any questions about your health, make sure you speak with your friendly neighborhood healthcare provider. And if you have any questions about your religion, make sure you check with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super, super excited to have on with me this very special guest coming into us from Chicago, Dr. Lauren Streicher. And Dr. Streicher, I will have you introduce yourself to those people that may not know who you are and what you do.
Well, first of all, thank you for having me, and so much to talk about. A lot of ground to cover here. But I wear a number of different hats. First of all, I wear some academic hats. I am a a professor of obstetrics and gynecology at the Feinberg School of Medicine at Northwestern University. I also am a senior researcher at the Kinsey Institute, which is an Indiana university, which of course is the premier location for
Yeah.
research in sexual function. And then I get out there and I talk to the world. I have a podcast. I write lots of articles for magazines. I have books that I've already written. I have more that's coming. So I am really kind of all over the place. And the other thing that's fairly recent that I do is I am the medical director of community outreach and education for MIDI Health, which is
Nice.
an online a company that provides medical care. We are not an online pharmacy. We are actually providing midlife care for women who do not have access, because we all know how hard it is to find
Yes,
a clinician
absolutely.
who knows this stuff, whether it's menopause
Hmm.
or sexual function. And last, what I always like to point out is when we talk about sexual function, there's so many different approaches. And what I do as a gynecologist is very different than what, say, a sex therapist does.
Hmm.
I stick to sexual medicine, meaning the physical, hormonal, biologic aspects of human sexuality. So, do I depend on my sex therapist? You bet. Do I depend on my pelvic floor physical therapist? You bet. But it's not what I do. I do the biologic, hormonal, medical.
Absolutely. That's fantastic. And that is absolutely a lot. So, so grateful you were able to find some time and come on to my podcast. So, actually, I'll be honest, I can't tell you the number of times I've seen your name quoted in the New York Times. So that's really impressive. I know they always, they tend to come to you a lot for a lot of their reports and their articles. But I'd love to hear about, I know you have quite a few books. And so I'd love for you to just tell me, and we only have, we don't have so much time, but I'd love for you, because you have so much, and gosh, I don't even know where to start. So you have the Essential Guide to Hysterectomy, you
Yeah.
have Sex Prescription, Hormones, Health, and Your Best Sex Ever. So I'm so curious about that book, and also the Slip Sliding Away, Turning Back the Clock on Your Vagina, and Hot Flash Hell. Well, I'd love to know what your inspiration was for all these books, and since you have so many, and I'd love for you to give us kind of a little synopsis, just so when people are looking for books.
Well, what's interesting is that I don't know why I went to medical school. It was just one of those things. I was an English and a dance major who was planning on being a journalist. So I always liked to write. And I did go to medical school. That's a long story. And very shortly after I finished my residency and I was practicing, my area of interest and expertise was minimally invasive surgery, hysterectomy, and alternatives to hysterectomy. And what I found is that when I had a consult with a patient about hysterectomy, I had about 10 hours worth of information I really wanted to
Yeah,
give that woman so that she can make appropriate choices. And I thought the only way this is going to happen is if I write a book. So I literally wrote a book as a way to counsel my patients. And that book took off.
amazing.
There were two editions to the Essential Guide to Hysterectomy. The first half goes through every single gynecologic condition you can think of, and not only hysterectomy, but alternative treatments. And then the second half is, if you're going to have a hysterectomy, how to make it the best experience of your life. And while that book is a little bit old and a little bit out of date, about 90% of it is still very much relative. So that's what kind of launched my writing career, if you will, in terms of writing books. And then Sex RX, Hormones, Health, and Your Best Sex Ever was intended to be a book about midlife and postmenopause sexuality, but the editors at HarperCollins very much wanted me to make it more comprehensive. So that really is a
Mhm.
guide to sexual health and sexual medicine throughout the lifespan, starting even with young women, because we forget even young women have problems with,
Yeah,
pain and libido and problems
sure.
having orgasm. So that was kind of the big sexual medicine book. And then as I got more and more into the menopause world and really began to specialize in that, I realized that most of the books out there on menopause, I really hated most of them. And even the ones I did like, what I really have appreciated in spending decades talking to women is they don't want an encyclopedia of menopause. They want someone to address their issue. And if their issue is painful sex, or if their issue is hot flashes, they don't want to buy a book that has maybe 2 pages on that and addresses everything else. They wanted to just focus on their problem. So my
Yeah.
original plan was to make my menopause series, Dr. Streicher's Inside Information on Menopause, about 7 or 8 books that I had planned.
Wow.
And so that's why I wrote Slip Sliding Away, Turning Back the Clock on Your Vagina, which is basically a book about genital urinary syndrome of menopause, which I'm sure
Right.
you have addressed with your
Yeah.
listeners, which is the vulvar, vaginal, and bladder symptoms that occur peri and post menopause. And then the second book was Hot Flash Hell, which really did the deep dive into hot flashes are not just about quality of life, which they are. It's also about length of life and the impact that hot flashes have on cardiovascular disease, on bone health, on brain health, on sleep, and then, of course, all the hormonal and non hormonal options that women have to alleviate those hot flashes. So that's what prompted me to write all those books. And then, of course, there's more in the works, more in the works.
Oh, amazing. You're amazing. So, I'd love to hear more about, the slip sliding away, turning back. So you talked about the gender urinary syndrome of menopause. You talk about hormonal medications then with that, I assume, and non-hormonal is that with that. And also, is it about orgasm? Is it about arousal? Is it about desire?
Yeah. Slip sliding away is not about orgasm and arousal. I covered that somewhat in Sex RX, and then I
Okay,
have something coming up that is very specifically going to focus on arousal, orgasm, pain, really sexual function.
sure.
Not to
Sure.
mention in my podcast, Dr. Streicher's Inside Information, I have many, many episodes that specifically look at that.
Okay.
But genital urinary syndrome menopause, as you know, is not just about sexual things. It's about the non-sexual
Yeah.
symptoms. So many women, they say, yeah, you know what? I understand that this can cause painful sex, but my concern is more things like vulvar burning, irritation, urinary frequency, recurrent bladder infections. So that's why I decided women really needed a book that did the deep dive. The other thing also is that so many books out there, they might say things like buy a lubricant, use a moisturizer, get a local vaginal estrogen, but that's not enough. Women
Mm.
want to know the details. They want to know what to buy. It's overwhelming. You walk into a store, you go to Amazon, and there's like 9 million gazillion lubricants. And quite frankly, 90% of them are not vagina friendly. Not only are they not going to be particularly slippery, but they actually might cause more problems, more dryness, more irritation. So this was really meant to be a very specific guide to help women navigate their way towards figuring out what to do. Women want to know specifics. It's not enough to say, I want a local vaginal estrogen. You need to understand what are the differences between a cream, a ring, an insert, a suppository. It's not just about personal preference. It's also about the very specific nuances of all of these products. And I am always very careful to point out I don't work for any of these companies. I'm not promoting anything. I have no financial relationships.
Sure.
This is just about from an expert, from an expert. What are the specifics? What's the difference between that little tablet you put in your vagina and the cream? So that's what women really need to know. They really, because their doctors aren't telling them. You know that. I'm sure
Yeah.
this is something
No,
you talk about all
absolutely.
the time. That when
Yeah.
someone goes to see a clinician, more often than not, they either have no expertise in this or very little expertise. So they're not
Right.
going to give you that kind of information. So this is really, I look at my books as being very much not only an education but a guide. What to walk in the door and tell your clinician.
Yeah. Yeah. No, I think it's fantastic. And I think it's really great that you really delve into all of the specifics because you're right. Most doctors don't have time. One, they don't know, right? So a lot
They
of
don't
doctors
know. They
don't
don't know.
know unless they go and specifically get education on all of this. But one, they don't know. Two, they don't have time, right? Like a 15-minute appointment is not going to get you all this information.
Right.
So it's
The other
great.
thing along those lines, one of the things that I think it's very important to point out is women get frustrated when they go to see their doctor, of course, or a nurse practitioner or whichever clinician they're seeing. And not only sometimes that person not have expertise, but even if they do have the expertise, most people allot 15 to 20 minutes for
Yeah.
their annual well woman exam. It's not enough. A
Yeah.
sexual medicine consult, a menopause consult, these things take a minimum of 30 minutes. And women sometimes get put off when at the end of their 15-minute visit and they say, oh, by the way, I can't have an orgasm and sex really hurts.
Yeah.
And they get the brush off. And it may be that that person's not an expert. But the truth is women need to prioritize this. They
Yeah.
need to make a separate appointment and say, I would like to make a separate appointment to come back just to talk about the fact that sex hurts. And that's the only way that women are going to get this kind of information. They don't hesitate to do it if they're having fertility problems. You know, if
Right.
at the end of an appointment, someone says, I've been trying to get pregnant for a year. And if they're told, come back and make a separate appointment to discuss fertility, they're like, okay. But the minute someone says, well, you got to make a separate appointment to discuss menopause or sexual function, people get like, what are you talking about? You know, I want to talk
Yeah.
about it now. And,
Right.
and, you know, we deserve better than that.
Right. And you're absolutely right. Like most doctors just do not have that time, and it's really important to prioritize it. And I just had somebody actually call me today for an appointment, and she's talking about how all of a sudden she notices that she's having this irritability, she's having these mood swings, and she said she's actually afraid to call her friends this week because she just feels that her hormones and her moods are all over the place, and she's
Mhm.
afraid that she's going to say something that she's going to regret. And so she's really, isolating herself. And I just, I had to sit in that for a little bit and think about like how menopause, perimenopause really affects women, and how then, when we feel like we're the only ones going through it, we tend to
Right.
isolate ourselves unless we have a platform, unless we listen to podcasts like, yours or mine, where they realize that they're not the only ones going through this and that there's definitely help out
Yeah,
there. But
you're so correct because the isolation is huge. And one of the biggest myths that we need to continue to dispel is women have this idea that I'm just going to tough it out because it's going to be just a
yes,
few months or maybe a
yeah,
year or so, when in fact, depending on your genetics, your ethnic background, you're looking 7 to 10 years
exactly.
at least that you're going to be going through these symptoms. And it just makes me nuts when people go, I'm done with menopause. You're never done with menopause. Your vulva and vagina are not suddenly going to start making lubrication just because you're done with hot flashes. So that's something that I'm sure you talk about all the time, but we need to continue to talk about because women have this idea like, okay, I'm just going to tough it out. It's going to be
Yeah.
okay. I'll get through
Yeah.
this.
Yeah, exactly. And I agree with you. I think it's also interesting when people say that, oh, I'm done. I'm done with menopause. How are you done? You have like the whole
Well,
rest of
it's
your
like
life.
my people talk about the definition of menopause as being when you've been without a period for 12 months. That is a ridiculous definition.
Yeah.
And in fact, I wrote, I'm on the editorial board of the journal Menopause, and I wrote an editorial about 7, 8 months ago called, we need to redefine menopause. And basically, I talk about the fact that this particular definition has been around for a very, very long time. And let's just face the fact that at least 1/3, if not more, of women in the United States and elsewhere in the world don't have periods. They've had a hysterectomy, they've had an endometrial ablation, they have a progesterone IUD. So they haven't had a period for Lord knows how long. And so this idea of you're in menopause when you've been 12 months without a period is meaningless. Meaningless. So the real definition of menopause is when you're no longer producing estrogen.
Yeah.
Period. Permanently no longer producing estrogen, whether it's because you've gone through surgery or chemotherapy or your ovaries have just wound down because they're done. That's what menopause is. And you're
Yeah.
never done with it because it's not like suddenly your ovaries are going to change their mind and say, oh, silly me, I'm going to start to make estrogen again. This is until you die. And women need to appreciate that.
That is such a great point, and I think that is a way that I, didn't really think about. But you're absolutely right. Menopause is when you no longer have estrogen, and that doesn't stop. It just continues unless you supplement, unless you do something about it. But it's never going to change. It's
Correct.
never going to go back.
And
And so
that's
that,
why, along those
yeah,
lines, one of the topics that keeps coming up is if you choose to take hormone therapy, how long should you use hormone
yeah,
therapy? And sometimes people are told things like, oh, 5 years, or you should stop when you're 60 or 65 or some other arbitrary time. And there's never been any science behind that. It's
yeah,
completely arbitrary. And in fact, well, certainly it's shared decision making in terms of figuring out how long you want to take hormone therapy. There's no law that says that you need to stop at 65. And there was a very recent study that came out with 11,000 women who were continuing their hormone therapy past the age of 65. And there was no downside and there were only benefits. So
right,
that's another myth that's out there. And then, of course, when we look at the vaginal stuff, one of the things I point out in Slip Sliding Away is that you should never, ever, ever stop using your whatever you're using, local vaginal estrogen, DHEA, because if you do, symptoms are going to recur.
Right. Right. Absolutely. So I'm curious to find out what you say to women. So I get women in the clinic all the time that say, like, when I ask them about their sexual health, if they're in perimenopause, menopause, they tell me, oh, I don't use that part of my life anymore. Like, I
Yeah,
don't use that part of my body anymore. I'm not sexually active. It's just not, that was done a long time ago,
yeah,
as if it's like, you're giving up smoking or something like
right,
that.
right.
What do you tell women that
Well,
say
this
that?
is my response to that is so the question I ask, I don't know what question you ask, but a lot of clinicians, they start the conversation by saying, are you sexually active?
Hmm.
And I'm trying to eliminate that question from the medical world because it's kind of meaningless. Women don't know why you're asking. They don't know what you mean by that because they might think, well, I wonder if she's asking because she wants to know if I need contraception or STI screening, or, if people are having sex that's not intercourse, they think that that doesn't count, or, it goes
Right.
on and on and on.
Right.
So,
Right.
so the question I ask is, are you satisfied with your current sexual function? And do you have any concerns about your ability to have intercourse, to become aroused, to have an orgasm? And do you have any pain? And the reason I say that is because people don't know what you're talking about, right? And
Yeah.
then to your point, a lot of women will say, no, 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 no. That's like, done, over. I don't care. I don't do that anymore.
Yeah.
My next question is, do you care? Is that a
Right.
problem for you? And
Right.
sometimes women say, no, I really
Yeah.
don't care. And then my response is, okay, if that ever changes, please know that there's a lot of things that I can offer that's going to help get you back. Because as you well know, a lot of times things do change. The reason they're not having sex is because they can't stand their partner, and what they need is HRT, husband replacement therapy. And then they get rid of the partner they can't stand. They meet someone new, and all of a sudden sex goes to the top of the list instead of the back burner. So, I always make a point of saying that might change, and then you can circle back. But if they do care, then obviously you're going to go down the road that you go down. But I think really that's the important point, is say, do you care? And if you don't care, know that I can help you. Because, and this is a personal theory of mine, I've always wanted to do this study. I've never done this study, is people that go through menopause that say that they don't care anymore, were they ever having good sex?
Yeah.
I think that women, we assume that young people all have good sex, and that's certainly
No.
not true. You and I know very well that that's not the case. So if
Yeah.
you have someone that's 45, 50, perimenopause, postmenopause, and they've never had decent sex, they've always had pain, they've never had orgasms, they just have a, lousy sex life, they're just as happy to say, now I've got an excuse. I'm done with that. Women who had terrific sex and enjoyed sex and were highly orgasmic, those are the ones that say, oh my God, help me, help me. Things are no longer like they used to be. And I don't want to give that up. 45, 50 is way too young to give that up. And quite frankly, if it's important to you, you never need to give it up. So that's how I approach it.
Yeah, and I think those are great questions, right? I love how the mnemonic for HRT is husband replacement therapy. I love that.
Well,
That's fantastic.
because we use, of course, the
All
term
right,
hormone therapy because we're not
right,
really replacing, we're just giving little amounts. And
right.
HRT is, and I think we need to acknowledge that sometimes people, it's psychosocial. They have partners they really just don't like, and it's kind of
Yeah.
like the big elephant in the room.
Yeah, yeah, absolutely, absolutely. And I think it's great that you do all of these follow up questions, right? Like if sex, is not something that you want or ever, are interested in, but did you ever enjoy it? Did you ever experience pleasure, right? Was that ever a priority for you or in your relationship? And oftentimes what we learn is that women are just not experiencing pleasure, that it's just not
Yeah,
something they've ever experienced pleasure, that they've have ever experienced an orgasm. And so when that part of their life, when they feel like that part of their life is over, it's not a big deal because they never really enjoyed
they
it to
never
begin.
enjoyed it. And even something as simple as the myth is still out there that women are going to orgasm during intercourse, during penetrative sex. And of course, we
We
know
know.
that's not the case. We know
Correct.
that that's really the exception, unless someone is doing, what I call pairing, having clitoral stimulation at the time of intercourse. But women don't know that. They think that something is wrong with them. They think that other women are having orgasms during intercourse, and they don't know that there are things they can do to facilitate that. So they just say, I'm done with this guy pounding away at me that really has never given me any great pleasure.
Right, right. You're absolutely right. And so I'm wondering, in your sex RX books, do you talk more about that? Do you talk about,
I do.
yeah, in
Yeah,
your
no,
hormones?
I do certainly talk about in my orgasm chapter the fact that many women don't have orgasms because of the expectation that they're going to have orgasms during intercourse. But the other area of interest for me that I'm doing some research on and that I'm
Mm,
focusing on are
yeah.
women who did have orgasms just fine, and then something changes postmenopause. And generally,
Mm,
that's because they have decreased blood flow and
yeah.
decreased nerve sensitivity in the clitoris. And not only is that fairly common, I mean, we're talking about that in some studies, over 50% of women postmenopause have acquired orgasmic dysfunction, meaning they never had it before. And then suddenly it's like, what the hell happened to my orgasm? But the other issue is that when we talk about clinicians not being knowledgeable, even clinicians that are knowledgeable about menopause
Mm,
very rarely are knowledgeable about women who aren't able to have an orgasm. And when
mm,
I do a lot of live events, and when I talk to a big group of women, and I say, okay, raise your hand if the last time you saw your doctor, they asked you anything about sex. Just use the word sex. And,
yeah.
like half the hands go up, right? And
Right.
then I say, okay, leave your hand up if they asked you if you were having any problems with sex. And about, at least, if not more, hands go down. And then I say, leave your hand up if you were ever asked if you're able to have an orgasm. Every hand goes down. I said, unless you're my
Yeah.
patient, but I mean,
Yeah.
too many doctors are not specifically asking about that. So women just kind of assume that there's nothing that can be done. And then, quite frankly, if they do ask, very often they have someone who just really doesn't know how to address it. And they say silly things like, have a glass of wine or something equally
Right.
offensive.
Right, right. And, I think that, there's so much that I feel in our medical school education that we just didn't get, right? We don't get anything, really hardly anything about sexual education. Maybe we learned something about from, Masters and Johnson, the research done in the 1960s and about the sexual response at that time. But as you know, that the sexual response cycle that we learned then is much different than what it is now with the human response cycle, right? That Rosemary Basson developed in 2001, where she talks about arousal coming before desire and how all these different things like the biopsychosocial model can affect whether or not a person is receptive to a sexual stimuli and how that affects everything else.
Right. It's way more complicated than, I mean,
Yes,
kudos to Master and Johnson for at least medicalizing it and beginning to study this and look at it.
right,
But we now know that the things that impact on the ability to have a pleasurable sexual response goes way beyond the work that Masters and Johnson did. It was a
right,
good beginning. But, and for me, the thing that I enjoy most about being at the Kinsey Institute, which is really an enormous research engine. I mean, they
yeah,
turn out probably about 400 articles that are published a year.
wow,
And when you look at how specialized it is, I'm doing one research project now that has to do with a new female internal liner, kind of. And we don't think of it as a female condom, but it's an internal liner. And when we wanted to do this research, which is launching now, looking at females' pleasure using that, and also men's ability to maintain an erection. So I went to the Kinsey people and I said, I want to do this research through Kinsey. And they said, oh, not a problem. We will connect you with our condom team. And I'm like, what? You have, they have, literally the world's authority on condoms. She's in the UK. She's part of the Kinsey group. That's what's so great. It's an international group. And this particular person, Cynthia Graham, has published, I don't know, hundreds of articles specifically on the use of condoms, both for male
wow.
sexual function and female sexual function. And I think, where else are you going to get that level
Yeah,
of
exactly.
specialty? So I have a
Absolutely.
number of research things going on with them now, and I just love working with them. I'm very, very lucky to be part of that group.
That is amazing. Yeah, no, definitely. I don't know of any other place that has a specialty in condoms. So that,
And that's only one of like dozens and dozens. I was working with someone who her area of expertise and all she's doing is consensual non monogamy. and,
Oh,
couples that
yeah, yeah.
knowingly have multiple partners. And this is her area of expertise. And she's written multiple articles about that. And so it's really very exciting work and very interesting work.
Yeah, I mean, I learned all about, those topics from the course that I took through the University of Michigan on sexual counseling and education. And I definitely would not have learned all those things had I not taken that course. I mean,
Yeah,
I think that there's so much lack of knowledge that we have.
yeah.
And there's only a few institutions that address it, right? And the
Very few.
key,
And the Michigan program, of course, I'm very familiar with, because I don't know if you know this, but my daughter is a sex therapist. She's a PhD,
oh,
and
no, I didn't
and
know that.
she did the Michigan program, and she's been a guest on my podcast many times because she knows all the stuff I don't know, and that you took the
Yeah.
course, so but she does amazing work, and she's just written a book. Her
Fantastic.
area of interest is pain, sexual pain, but she does a lot of other things. And in
Wonderful.
fact, the podcast episode of my favorite one that I did with her was on faking orgasm. How many women fake orgasm, why they fake orgasm, and men too fake orgasm. So we've done a lot of fun episodes together, and we do a lot of events
Um,
together. She's quite wonderful.
That
So
is
yeah, she did
amazing.
the
Yeah.
Michigan program.
Yeah, yeah, that Michigan program is fantastic. Wow, I'm gonna have to look up your daughter now. I had no idea that she was a sex therapist.
Rachel
She's a
Guy.
sex
Follow
therapist.
her on social. She's quite fabulous. And I'm not
Oh.
just saying that because I'm her mother. This is other people also say how
No,
fabulous she
I'm sure.
is.
I'm sure, yes. So, what I find interesting also is, how people make the distinction between spontaneous and responsive desire. And I know we're shifting a little bit, but, what is your take on that? I know that some people say that it's two separate things. And then I had Rosemary Basson on who did a lot of work on that with Lori Brotto. And
Yeah.
she believes that there's no such thing and that the only thing is responsive and that people, we think it's spontaneous, but it's really not because people have been thinking about, what they're going to do, how they're going to do it, whatever. And so it really essentially is
Yeah.
responsive because they've been primed, their
Well, that's
brain is
exactly
primed.
right. And certainly when I look at the work of Lori Brotto and Rosemary Basson, I am completely on board with their approach because they are correct. And
Yeah.
and one of the things actually that my daughter, Dr. Zara, and I have talked about a lot is the idea that even if you think it's spontaneous, it doesn't really exist. You've
Yes.
been prepping, you've been thinking about it, whether
Yeah.
it's that you are shaving your legs or putting on your good underwear in preparation for the date you have that night. This idea that you are going to be completely out of the mood and then out of nowhere, suddenly you're going to want sex. It doesn't happen. It's
Yeah.
always responsive, but that responsive looks different
Yeah.
depending on the timeline of your relationship, where you are in your relationship. And where it becomes really important is this idea of people who've been in relationship for a long time and have this expectation that they're supposed to take one look at each other and rip their clothes off. And then when it doesn't happen, they think, oh God, something's wrong with us or the relationship's dead. And that's why people need to have date night. That's why they need to
Yes.
think about what they're going to be doing with that person who's been in their life for 30 years. We talk about the
Yeah.
monotony of monogamy,
Yeah.
and it's so important to shake it up. So I'm with you 100% that
Yeah.
we need to appreciate about responsive desire.
Yeah, and I feel like when people really start to understand that, then they don't feel like there's something wrong with them, right? That
Right.
there's, that they aren't able to be whatever they think, as spontaneous as what they see on the media because they realize that it's everything is responsive and that I've been thinking about this for quite a long time and that's why it's happening for me. It's not that there's something wrong for me. So I think that that's for me at least that's one of the main reasons why I think it's so important for people to
Hmm.
understand
Yeah.
that. So you were also talking about, orgasm and how orgasm gets muted as people go through menopause and, as
Yeah.
they are living longer and things like that. So aside from, let's say, estrogen, vaginal estrogen, do you think that, because vaginal estrogen helps to bring the blood flow back into the vulvar region, do you think that there are other things that people can do to help with the orgasms as they get older?
About a
And
million other things. Let's start with vaginal estrogen.
yeah,
Vaginal estrogen isn't necessarily going to get to your clitoris. You got to go
yeah,
north. If you are using an estrogen cream and you put it inside your vagina as instructed, Well, you're not done. You know,
Yeah.
you put it on the vestibule, the opening, because it doesn't matter how nice the room is if you
Right.
can't get through the door. So you got to put it on the vestibule. And then you start to go north. You put a little bit on your urethra to help with those urinary symptoms. And then you keep going, and you are going to use estrogen cream specifically on your clitoris. And even if you're using a different estrogen product, a ring, a tablet, whatever, you still get a little tube of cream specifically for that purpose if you're having trouble. Because what estrogen is going to do specifically is not only is it going to prime those estrogen receptors, but estrogen's a vasodilator. And really what it
Mm,
comes down to is blood flow. You need to increase blood flow to your clitoris, not only because that will help you get aroused, but you need healthy blood flow in order to have healthy nerve endings. I mean, you think about it, what makes our nerves healthy?
right. It's a
It's
blood
having
flow.
decent blood flow. And what happens is that not only are your nerves suffering because of just the normal aging process and because they no longer have estrogen to help, but then we also have to be realistic that 50% of the population over the age of 50 has other medical problems, whether it's
Yes.
diabetes, cardiovascular disease, so many things that are going to impact on clitoral health, not only blood vessels, but nerves. I mean, take diabetics. I mean, we know that the number of diabetics in this country is sky high for a variety of reasons, and prediabetes and metabolic syndrome and all of that. And people are generally very familiar with foot neuropathy, you know, the fact that you are
Mhm.
going to have some numbness in your feet from diabetes. And that's something that doctors will ask about all the time. But do doctors ever ask about clitoral numbness, clitoral
Mm,
neuropathy? They don't. But the same people that are getting foot neuropathy are also getting clitoral neuropathy. So,
yeah.
so yes, so you are 100% correct. Estrogen is very, very important, but there's certainly other things people can do that are going to help blood flow to the clitoris. And um, we know that testosterone may be helpful, not applied directly to the clitoris, but systemic testosterone is also going to help with arousal, with blood flow. I've been doing some work with CBD, with
Mm,
cannabis, because interestingly, we have not nearly enough research, but CBD is a vasodilator, and it has been shown in diabetics to help peripheral neuropathy, not only in
mm,
terms of increasing blood flow, but increasing nerve sensitivity and decreasing inflammation. And while you can't always make the leap from one part of the body to another, you know, we don't want to overstretch, but we don't have data right now in the clitoris. But anecdotally, a lot of diabetics and other women as well say that by applying a little CBD to the clitoris, they're going to get increased blood flow and increased sensitivity. You know,
wow.
certainly we know that using a vibrator is going
Yeah.
to stimulate different nerve endings than are stimulated with soft touch or licking. You know, a lot of women say, well, I had my go-tos that always worked for me to have an orgasm, and now it's not working anymore. It used to be that with manual stimulation or oral stimulation, that would be just fine, and now it's not. And it's because those nerve endings actually lose their sensitivity sooner than the ones that respond to vibration. So for women
Mm,
not using a vibrator, that would be something very important to incorporate. So, I mean, and I could go on and on and on. There's a million different things that can be done to facilitate the ability of those nerve endings to be responsive. And it's not just enough to take estrogen. It's a good first step, but for a lot of women, they need a lot more than that.
yeah, that's fantastic. So, I know that you've done a lot of work on vibrators as well. You
Yeah.
talk a lot about vibrators. So, I'm curious to know if there's a vibrator that you recommend, or is there one? I mean, I know you don't want to, name names, but is there one that does something different than another vibrator that you think helps more for women to achieve orgasm, or they all serve their own purpose differently?
Yeah, I actually don't mind naming names because sometimes I do name names. I just always say that I don't have a financial relationship with these
Sure.
companies because a lot of people think you name names because they're paying you to do so.
Yeah.
So I think, in fact, I do name names all the time because I think women need specifics.
Sure.
And when it comes to vibrators, I'm actually in the process of putting together a new episode about vibrators, which I've hesitated to do because not that I'm shy talking about vibrators, obviously I'm not, but I think that it's important sometimes to do a little show and tell. And
Mm,
obviously on a podcast, you can't do that. And while I
right.
do put a lot of my episodes on YouTube that you do as well, I don't get a lot of traction there for some reason.
Yeah.
I did just do a really, really fun podcast episode that aired first week in October, I think.
Hmm.
That
Hmm.
is, I call Gyne Hacks, and it's all kind of like fun little tips and tricks to do things that I can assure you your own gynecologist hasn't told you. Things like how to get out your string if you can't get it out, and how to get a nice vulvar view. But one of the things I talk about along the lines of this is how to use your electric toothbrush as a vibrator. And I don't recommend that routinely. I just want to be clear about that. But if a lot of women do that, if they're in a pinch, if they're traveling, if they're in a hotel room someplace, I talk about how to safely do that. So to your point, is there a best vibrator? There really isn't, because as long as you're using something that's going to give you clitoral stimulation, a lot of it is, what is going to be your preferred approach, whether it's having your partner hold the vibrator, you hold the vibrator, it's for solo play, it's for partner use. There's so many different ones out there that it's really a matter of finding what's the best for you in terms of what you're looking for. And of course, I think people should own multiple vibrators depending on what they're doing. But I think the most important thing is really kind of give women, again, we talk about recommending specific products when it comes to lubricants and moisturizers and estrogen and all that. And I can say the same for vibrators, is
Hmm.
to, to really kind of get into the specifics. One of the, I write for a number of magazines, and one of
Yeah.
the magazines I write for is called The Ethel, which is an AARP magazine. And I did publish an article not too long ago called Vibrators 101, like a guide to vibrators.
Oh, fantastic.
And so that if people are interested in that, that's if you just go to the Ethel, Ethel, and put my
Uh-huh.
name in, and all my articles pop up, and my vibrator article is there. But I do have a podcast coming on that one.
Oh, that's fantastic. So I know you also mentioned about testosterone, and we
Yeah.
briefly talked about that. But I know that there's been a consensus statement that came out back in 2019 with a bunch of organizations that said that testosterone was actually safe. And although we don't have an FDA-approved formulation here in the United States, and I know that Australia has one,
Mhm.
but we don't, and so women end up having to go to a compounding pharmacy for
Right.
their testosterone, or they'll get the testosterone patch, right? But we know that that's a controlled substance. And so sometimes it can be difficult for women to get that. We know that the major indication for testosterone is hypoactive sexual desire disorder. But
Yeah.
are there other things that you would recommend? I know that sometimes women feel like low energy and, kind of that brain fog when they start to go into menopause. What are the things that you tend to prescribe testosterone for?
So you know that this is really controversial, and why you why
I
you brought it up. And in fact, I just did a podcast episode with my friend Kelly Casperson, because she's one of the people on social media who is out there talking about testosterone a lot. And she's a good friend, so I can give her a hard time. And I started off the episode by saying, okay, Kelly, so what? Every single person should be using testosterone? And of course she said, no, 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 no. I never said that. And I'm like, really? But
Yeah.
but this is the thing. I mean, we know that we have very good data that shows that if testosterone is prescribed in the right way, in the right dosages, with the right monitoring, that it does appear to help with sexual desire, with libido. In about 50% of women. It's not like it's amazing. It's not like every single woman is suddenly going to have a great libido. And that's because libido is so multifactorial, and there's so many other things that
Yes,
impact on that. But
of
it does
course.
help about 50% of women. But to your point, the question is it going to help with, there's a very long list of other things, whether it's muscle mass or energy or, cognitive function or fragility. I mean, it just goes on and on and on. And the answer is we have emerging evidence that shows that might be the case. We don't have the kind of solid science that we would like to have. Um, and there's really, this is what's so controversial in the menopause space right now. Do we wait for that solid science, which may or may not happen, or may take another 10 or 15 years?
Yeah.
Or do we just kind of go with what we know? And my approach is we tell women what we do know and what we don't know, and we have to be very transparent that we don't
Yes.
necessarily have the kind of science that we want that proves that it does do, fill in the blank. But having said that, we have emerging evidence that it may help with things in terms of kind of a sense of well-being, with energy, potentially with decreasing, fragility and some other things. It does not appear to help with the loss of muscle mass that women have, sarcopenia. It may help with preventing it. We don't really know. So when it comes to testosterone, my real message is we don't want to oversell it. There's a lot that we don't know. But what's most important is if you're going to go down that road, please go to a clinician who has real expertise and is going to do this carefully and appropriately. And the
Sure.
biggest red flag, of course, is someone who's out there giving you pellets or telling
Right.
you that every single woman needs this and is having you
Yeah.
do all kinds of crazy saliva testing and Dutch testing and all that kind of stuff that's not only unnecessary, but it's inappropriate. And quite frankly, especially when we're looking at pellets and other high dose approaches, it can be really dangerous. At the most recent Menopause Society meeting, there was a wonderful lecture by an otolaryngologist who was talking about the impact of menopause on the voice. And
Mm.
one of the things that she was talking about, and I talked about this in my podcast episode that is live the week of October 12th. I was giving an update of all the research that was done by
Yeah.
Menopause Society. And she talked about the fact that she's seeing a lot of women in her clinic that have been given prescriptions for testosterone, for libido or whatever else, and they
Yeah.
get lowering of the voice, and that
Yes.
they were not told that that could happen. And it
Mm.
is not reversible. It is not reversible. And women sometimes are told, well, you might get a little extra hair growth, or you might get some acne, or your skin might get oilier, or maybe you'll get a little bit of clitoral enlargement, but they're very, very rarely told about the voice changes. And for some people, it's quite subtle, but for other people, it's not. And
Wow.
particularly if someone uses their voice professionally, maybe as a
Right.
singer or a voiceover, this can be career killing. And so this is one of the many things that we need to be very careful to let women know about before we just write a prescription for testosterone.
It's amazing. And I'm so glad you bring that up. I wonder if that's more with like super physiologic doses, right? If we're going above and
Definitely with
beyond.
super physiologic doses.
Right.
But
Yeah.
her point was, and
Right.
that's actually something that we all talk about all the time. Hey, if you're going to take super physiologic doses, doses that are higher than what women ordinarily make, then
Yeah.
yeah, you're much more likely to get these kind of side effects that are not reversible. But what her point was even in physiologic dosages with
Mm.
supplementation, they're seeing this because we know there's a wide range of physiologic dosages. And for
Yeah.
some women, even just a little bit higher is enough, especially if their levels are not being closely watched. So, it's just goes under the heading of you need to be educated, you need to know. And if women are given good information, they'll make good choices, but they need to be given the information.
Absolutely, absolutely. I wonder how long she noticed that. Like, I wonder if it was like women that had been on testosterone for like years, or if it was,
Well, that
like,
was the $1 million question, and during the Q&A, she was asked, "What is the length of time? What are the serum levels? And what are the dosages that you're
right.
starting to see these voice changes?" And her answer is, "We have no clue. It's all over the
Mm,
map. It hasn't been well studied." And
okay,
she thinks, and I don't disagree, that every single woman that is put on testosterone supplementation, even if it is being done appropriately in appropriate physiologic dosages, needs to be told that this
sure,
is a possibility,
sure.
small in normal physiologic doses, but certainly a possibility because for some women, this is a big deal.
Yeah, that's an
And
excellent
again, it's
point.
not reversible. Once that's what it is.
Right, right. No, it's such great information. So, I'm curious if there are a few pearls that you think people should absolutely be aware of. As I notice that our time is starting to come to a close, I'd love to know if there's something, that you're like, three big pearls that people should leave this episode with that they should absolutely know about.
Well, number one is if your clinician is not giving you a solution, it doesn't mean that there isn't a solution.
Mm,
Women just don't prioritize their own health. They don't prioritize their own pleasure. And so
absolutely.
often they go to their clinician, their doctor, and they ask a question or it doesn't come up and they just figure, I'm done. And in fact, there is always someone out there that can help them. And one of the things that people say, well, how do I find that person? And we both know how challenging that is because the numbers are quite low. It's
Yeah.
actually one of the reasons I got involved with MIDI Health because while it is telehealth and in a perfect world, very often women need to have an exam,
Of
but
course.
because that's all they do is midlife health and menopause, including sexual function, they can be very knowledgeable, and it's a way,
Yeah.
and they take insurance, and they're in all 50 states. So it's a way that women can have access to things like, not only local vaginal estrogen and DHEA, but testosterone if you have a state where it's not a controlled substance. And so that's number one, is there is help out. There is help out there, even if you haven't been getting it. Um, the second thing that we didn't talk about, but I just want to touch on for a second, is a lot of women start with using a vaginal lubricant if they're having
Mm.
painful sex, and then if that doesn't help, they give up. And we know that a lot of times it's because they're using the wrong lubricant. There are a lot of lubricants
Mm.
out there, particularly the water-based ones, that are
Yeah.
irritating, that are not particularly slippery. So one quick little pearl is,
Yeah.
if you haven't tried a silicone-based lubricant, start with
Those are
the
the best.
silicone are the best, the most vagina
Right.
friendly, and
Mhm.
slather it on. You put it in the
Yeah.
vagina, you put it on the vestibule, on the opening, put it, if you have a penis in your life, put it all over the penis. Do not be stingy with your lubricant. The more, the better. So I think that's another little thing. And then the third is, I can't emphasize enough, if you are using a local vaginal estrogen, make sure that you're also putting it on the clitoris. Get that vibrator if you don't have it. And if you are afraid of using a local vaginal estrogen, thinking that somehow it is going to increase your risk of breast cancer or blood clots or any of the other things that says that on that label, that FDA label, it is not true. There's a group of us that are working very hard to get those warnings off the label, because none of them have any scientific basis at all. So don't let that label scare you away. And if you have a clinician who has told you that you're not a candidate for local vaginal estrogen, I would encourage you to get a second opinion, because there's virtually no woman that cannot successfully and safely use a local vaginal estrogen product.
100%, 100%. Those are amazing pearls. One thing I wanted to ask you, and yeah, I'm afraid it might get into like a whole another discussion, but when you mentioned about putting the vaginal estrogen on the clitoris, have you ever seen it causing like clitoral phimosis with the hood? I know that we're supposed to be teaching women about pushing that, the
Yeah.
prepuce back, so that it doesn't form those adhesions, but any
Well, it prevents,
scientific.
basically it prevents that sticking of the hood to the clitoris, because when you look at why that happens, certainly there are a number of medical conditions that can cause that to happen, such as lichen sclerosis and other things I'm sure you've
Okay.
talked about. But sometimes it's just simply from atrophy, from the tissue becoming
Mm.
dry, and from lack of estrogen. So if
Ah,
women from the get go are applying a local vaginal estrogen to the clitoris, that very often will prevent that from happening. And
okay.
it's not going to make it go away once you have it, but it can prevent it. So there's really no downside to applying a local vaginal estrogen to the clitoris, and to the foot of the clitoris, the prepuce, and it actually increases the health.
Amazing. This has been such an amazing episode with so many pearls, and I have you to thank for all of this. It's just been such an amazing conversation. So, for all those people that are sitting there watching you, listening to you, and thinking, wow, she is amazing, how can they get in touch with you? How can they perhaps follow you or, work with you? How could they do that?
Well, the best way to follow me, of course, on social media, I'm on Instagram, Facebook, LinkedIn, trying to get a little traction on TikTok. I think I have maybe 2 followers on TikTok, working on that. But I am at
I'll be
Dr.
your third. I'll
Oh,
follow you.
thank you. Thank you. I appreciate that. At Dr. Streicher, Streicher on Instagram. I'm at Dr. Strike, Streich, trying to change that, but so far haven't had any luck. And my podcast is Dr. Streicher's Inside Information, which is on all platforms. And if you want to know what I'm doing and events and all kinds of things, just sign up for my newsletter, which if you go to any of my social media accounts in my bio in the LinkedIn tree, all you've got to do is hit um, that you want to sign up for my newsletter. And if someone has a topic or a question that perhaps they would like me to answer on my podcast, I don't answer questions individually because, as you know, I could spend
Right.
all day, all night doing that. But I
Yeah.
do absolutely hang on to those questions and topic ideas and use them for podcasts. And in fact, the third week of October, I did a Q&A podcast which is all about cancer questions, women at risk of cancer,
Mm,
women who are concerned about cancer, women who have a cancer diagnosis, not just breast cancer, but every kind of cancer. And that is 100% based on questions that have come in through the website, through social media. And my website is drstreicher.com. So that's how you find me.
amazing. Amazing. Love it. So, well, thank you so much for your time. I know it's super precious and you are a very busy woman. So I really appreciate your time and coming on and doing this episode with me. So thank you so much.
Been my pleasure.
And well, we are done here and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions, make sure you go speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.